Good afternoon, everyone. Welcome. We are so happy you could join us today, and I'm Sharon Reichardt Walker. I'm pleased to be here to host and moderate this webinar for Brain Support Network, a nonprofit focused on education for PSP, CBD, MSA, and LBD, and brain donations for all neurological disorders. Over 600 people have registered for today's webinar. They are from around the US, Canada, and many other countries. As well, we have both lay people and healthcare professionals attending. A little bit about my background. I cared for my late husband, Dennis, who passed away in 2007. His PSP diagnosis was confirmed following his brain donation. Following his passing, I was a BSN support group volunteer and sat on the BSN board from 2012 to 2016. I am currently working with organizations to help support caregivers. Stanford and BSN are very pleased to offer the fourth in a series of webinars. Today's webinar focuses on PSP, MSA, and CBD. It includes what symptoms are amenable to improvement. How can physical therapy, occupational therapy, exercise, and assisted devices help? What about eye movement training? What about Botox? What are some eating and drinking strategies? How can you ask your neurologist about these treatments? We are recording today's event and uploading it to YouTube, and we are hoping you can pass it along to others who might be interested in what we have to say. Watch your email after the event for the link. BSN will also be posting a summary of the events on our website. We also ask you to complete the survey after the webinar concludes. We look forward to receiving your feedback. It will help us in improving our webinars going forward. Our guest speaker today is Dr. Brent Bluett. Dr. Bluett is a movement disorders specialist at Stanford University. He is an expert on atypical Parkinsonism disorders. He is director of the Stanford Center for Excellence for Progressive Supranuclear Palsy. Dr. Bluett's research focuses on fall prevention in all movement disorders. He received NIH grant funding to explore freezing of GAIT in Parkinson's disease in order to better understand the underlying pathophysiology. After Dr. Bluett's presentation, we will hold a Q&A. At this time, I'd like to turn things over to Dr. Bluett.
Good afternoon, everybody. I wanted to thank everybody for being here. Just want to make sure that I am being heard, first of all. Sharon and Robin, can you confirm?
You are being heard.
Okay, great. I'm sorry. That's just that last check. Thank
Okay.
you. So I wanted to first start off. The title of the presentation is Treating PSP, MSA, and CBD, What Can Be Done? A brief, first of all, most importantly, I think that everybody here recognizes and that Sharon and Robin are doing something amazing. I want to give them credit, first of all. A bit about myself. My intern year of residency, my mother had colon cancer. I saw what it's like from the patient's perspective. When the doctor doesn't call you back for 5 days, when your loved one is sick, it's terrible. It's a horrible thing, and I always promised myself I would always remember that and never do that to my patients. So what Robin and Sharon have done by taking something that's tough, and everybody who's on this webinar is probably going through something similar, and learning from it and then using it for a positive, that would probably be my most important message today. But I wanted to thank Sharon and Robin first of all. So I'm going to go through the presentation relatively rapidly. I think that's important because we have so many questions, and this can be referenced again on YouTube later. So I don't think there's a need for me to slow down. I'll get through the information. You will have it accessible. I hope to answer all of your questions. I understand we have a large amount of people. I want everyone to be happy. So part of what I'm going to do is present in terms of that doctors use. Now, this is to bridge the communication gap that often occurs. We're taught literally in Latin. Most of these terms are in Latin. We don't often communicate these in English or whatever language might be necessary for the patients and their caregivers. So please excuse some of the terms. I will try to explain everything in layman's terms so we're all on the same page. Parkinsonism is a term used to refer to disorders which resemble Parkinson's disease. Atypical Parkinsonism includes 4 disorders. They all have 3 letters. They're acronyms: PSP, MSA, CBD, and LBD. We will be discussing the first 3 today. PD, MSA, and LBD are due to abnormal accumulation of the protein alpha-synuclein. PSP and CBD are due to abnormal accumulation, of the protein tau. There is currently no cure for Parkinsonism, but the incidence of these disorders is increasing. The reason that I mentioned that the proteins involved, the tau, most importantly for PSP and CBD, that is also the protein that accumulates in the brains of Alzheimer's. I think everybody here knows that Alzheimer's is increasing in incidence rapidly. Therefore, there's a ton of research and a ton of funding going into trying to figure out a cure for Alzheimer's. This trickles down to our PSP and CBD population. And so therefore, because the tau protein is responsible for all 3 of these disorders and another one called frontotemporal dementia, it is very important right now and a very huge focus of the government, of medical societies to find cures for these. So although we don't have a cure right now, my hope is that the funding will help us find one. Okay, so today we'll discuss the management of the symptoms for these disorders. So first of all, who should be managing my symptoms? A movement disorder specialist. That is what my training is. I'm obviously biased, but we are trained in the diagnosis and management of atypical Parkinsonism. And there are a plethora of movement disorder specialists. I would recommend finding someone. You can usually look online at their bio and see if they have a mention of atypical Parkinsonism as one of their areas of expertise. It typically takes 3 years before those with atypical Parkinsonism are sent or referred to a movement disorder specialist. An early intervention is obviously very important for your overall health. And we may be aware of clinical trials for your disorder. And I wanted to share this link with you. I thought this was very important. This is clinicaltrials.gov. I want to give you the power that you deserve. So if you enter a condition, put in progressive supranuclear palsy, corticobasal degeneration or syndrome, and multiple system atrophy, and it should show a list of the clinical trials. What you want is recruiting or enrolling by invitation. That there's a checkbox for each of those. That gives you the power to basically be able to find these trials for yourself. Your physician should also be aware of them as well. So this is a bit esoteric, but I wanted to show you how we diagnose atypical Parkinsonism. We'll discuss the CBD, PSP, and MSA specifically. So Parkinsonism is a unifying term. It is unified by the presence of bradykinesia. Bradykinesia is slowness of movement. Brady, slow, kinesia, movement. So if there's no or minimal cognitive impairments, that leads us either to multiple system atrophy or Parkinson's disease. Please understand this is obviously a very simplified version. There's much more nuances, but this is an overview. For corticobasal degeneration, dementia with Lewy bodies, and PSP, I'm going to skip down to the bottom squares. So with corticobasal degeneration, it's strikingly unilateral presentation. I saw one of the questions was already discussing that. So there's limb rigidity, akinesia. Rigidity is stiffness, akinesia is lack of movement. Dystonia. Dystonia is abnormal involuntary muscle contractions, or myoclonus. Myoclonus is a tremor, but a tremor is oscillatory and rhythmic. Myoclonus is a bit jerky. There's also orobuccal, which is mouth and tongue, or limb apraxia. Apraxia is an inability to use the muscle that you intend to use. It's basically due to a miscommunication between the brain and the intended movement. Cortical sensory deficit, that means that sometimes people feel that their limb on the side that's affected is not their own. That leads to the alien limb phenomenon. You'll see here, unfortunately, this poor response to levodopa, the major medication that we use to replace dopamine for Parkinsonism-related disorders. Before going on to PSP, I want to point out, unfortunately, again, poor response to levodopa, you see that for corticobasal degeneration, dementia with Lewy bodies, PSP, MSA, not Parkinson's disease. So Parkinson's disease is usually amenable to carbidopa-levodopa. I'll discuss this a little bit later in one of the slides upcoming. So for PSP, essentially what we have is Parkinsonism, again, the slowness of movement. It's usually bilateral. Both sides of the body are mainly symmetric, then affected both sides equally, whereas corticobasal, again, is one side. PSP is early falls, usually backwards, and inability to look up or down. For multiple system atrophy, again, little cognitive impairment at the beginning of the onset of the motor symptoms, but there's autonomic dysfunction. This is a general medical term. It defines our sympathetic and parasympathetic nervous system. I'll make it simpler. Autonomic symptoms are orthostatic hypotension, which is lightheadedness when you stand up, severe, and urinary incontinence. Those are the two major hallmarks of MSA that we see. So there's also early postural instability and falls as well with MSA. And again, this poor response to levodopa. Cerebellar signs are ataxia, basically difficulty with coordinating fine motor movements. So that's just an overview to let you know how we, from our side, diagnose these disorders and to make sure, honestly, that you have received a proper diagnosis. So for the motor symptoms, let's discuss what we can do. Because although we're waiting for a cure, we don't have time. We need to make things better now. So does carbidopa-levodopa work? Again, what we do is we use the 25-100 milligram tablets. A sufficient trial is 2 pills 3 times a day. Each tablet is 100 milligrams. 6 in a day times 100 is 600 milligrams daily. We always recommend a slow, gradual titration. If a physician tells you to take 2 pills 3 times a day at the beginning, you will likely get sick. That is not the recommended way to do it. Again, more reason to see a movement disorder specialist. So 25 to 33% of atypical Parkinsonism patients will have a significant sustained response to levodopa therapy. And I wanted to put this in here that PSP Parkinsonism, a subtype of PSP, tends to have a more robust response with greater improvement of symptoms. I'm always quick to point that out because that is a positive aspect for any patient that I see with that. If you're wondering, how do I know if I have PSP Parkinsonism? It's PSP, but there's usually more one side affected than the other, and oftentimes a resting tremor will be present as well. Now, there's another kind of medication we use for dopaminergic purposes. They're called dopamine agonists. I put the names down here. These should not be used for PSP, CBD, or MSA. This is because they can cause many side effects. Oops, sorry, let me go back. They can cause impulse control disorder, excessive daytime sleepiness, and or worsen lightheadedness when standing. Now, let's talk about postural instability and falls prevention. This is important in all 3 disorders. Number 1 is physical therapy. Do not underestimate the importance of physical therapy. It is huge. If you find the right physical therapist, you will be in good hands, and they can do as much or more as the medications. You want somebody whose training focuses on increased amplitude of movements like LSVT big or power. Focus on postural stability and gait training. Gait is walking. And balance, eye movement, and visual awareness training may improve gait and PSP. Chris Zampiri gave a presentation a while ago. She has an article that she published back in 2010, and the eye movement training can definitely be very effective. That is a question that I've received also, so I'll address that again at the end. Exercise, huge. If you don't use it, you lose it. Core strengthening is very important to keep balance. Aerobic exercises that are safe and as tolerated. Occupational therapy is similar to physical therapy, and what they can do is often provide a home health assessment that can be beneficial for understanding ways to make your home safer so you don't trip or fall. Evaluation for lifting devices or wheel mobility aids. They focus on optimizing upper limb function. And I want to take a step back. Occupational therapy is very valuable. I'll be honest, when I came into the medical field, I did not know much about occupational therapy. I knew about physical therapy. Occupational therapists focus specifically on what your problems are and your deficits. They're very, very, very valuable. I usually ask anybody I see to see them at least once. Just give them a shot. And if you don't like it, you don't have to go again. Most people keep going. Assisted walking devices are huge. Cane, walker, or wheelchair. A weighted walker may help prevent falls backwards. This is very important with PSP. I oftentimes see people come in with these little walkers that have the wheels, and they're very light, and I can see that they're not going to help anybody's balance. So please speak with your physician or physical therapist about the weighted walker. Orthostatic hypotension. Again, this is one of these terms that we throw at you, and we don't understand that you don't know these terms. Orthostatic hypotension is lightheadedness upon standing, and it's severe in these disorders, especially with multiple system atrophy, more so than with other disorders. Conservative measures should always be taken first. You don't want to go too far. So increase water and salt intake, stand up slowly. That's the most important. I'm going to go back for a second. Slow. Take your time. Do not rush. In PSP in particular, there's an impulsivity component of standing up and wanting to run. Everybody who's a caregiver knows this. And you just have to advise the person to please take their time to prevent falls. Exercises like leg crossing, squatting can reduce lower body blood pooling. Avoid alcohol. Also, autonomic stressors, things like hot water. Hot showers are the most dangerous place to fall. This is why occupational therapy can be important. I think most of you probably know already that shower chairs can help reduce the risk of falls. Things of this nature are huge. Thigh-high compression stockings with or without an abdominal binder. Sleep with the head of the bed elevated, at least 15 to 30 degrees. Now, if you're taking medications that can lower blood pressure, you only want to discontinue that medication if the risks outweigh the benefits. If somebody has extremely high blood pressure, they're going to need to take a hypertensive medication. So speak with your physician about this. They should review your medications and see what they can do to find the medications that could be causing this problem. Now, if the conservative measures don't work, we go on to medications. And I know you're not going to prescribe these for yourself, but I want you to have this information so that you can present this to your physician. This isn't a formal recommendation of how to proceed with lightheadedness upon standing. The first one is pyridostigmine. And then if that doesn't work, then use what are called, pressor agents. Pressor agents raise the blood pressure. Midodrine, this is honestly the easiest, the simplest. To use. Droxidopa is very effective. It's a little bit more complicated. It takes more adjusting, but it's very effective as well. Fludrocortisone is a last resort. The reason I say that, it's also called Florinef, fludrocortisone. It can cause leg edema. This causes more difficulty walking and increases your risk of falls. So I tend to steer clear of that. Then there's something called postprandial hypotension. After you eat, the blood rushes to your stomach, makes you lightheaded when you stand up. There's something called acarbose that can help with that if that's a problem. Freezing of gait. This is one of my research focuses. It's an inability to walk despite the intention to do so. It is a feeling that one's feet are glued to the ground and that they cannot move. It typically happens in 5 situations: starting to walk, going through a narrow doorway, turning or reaching one's destination. Also when trying to do 2 things at once. Simplify when you walk if this is a problem. Tune everything else out. Just focus on walking. Don't talk walk. If you have gum, you spit that out. Whatever you need to do to just focus on the walking. And so this is one of the most disabling symptoms of Parkinsonism. It's a frequent cause of falls as well. So how do we treat the freezing of gait? First line medication, rasagiline, very few side effects from this medication, often not as effective as the second line, amantadine. Amantadine works a little bit better in my experience, 100 to 200 milligrams. BID is twice a day. And amantadine can cause a little bit of confusion, and so I usually avoid giving that in the afternoon or evening because it can cause hallucinations as well. Our first motto as a physician is do no harm, but often every medication has a side effect, so we have to be careful. These are the potential side effects for amantadine. Often they don't happen, but we do want to monitor for them. There's physical therapy has come up with honestly better ways of treating freezing of gait, rhythmic auditory cues. focusing on a line on the ground to step over, assistive devices that project a laser light on the ground to simulate a line to step over. This is done with 3 different ways. A weighted walker has this, a cane has this, and now there are shoes that have a laser light. If you Google laser light freezing of gait, you'll find this. Cervical or limb dystonia. Again, dystonia is that phrase that I used earlier. These are abnormal involuntary muscle contractions that cause posturing. So that's the definition right there. In the cervical or neck region, what this manifests as is neck stiffness, rigidity, tremor, a limited range of motion. I see this in pretty much every atypical Parkinsonism patient that I have. Excuse me, CBD, MSA, and PSP. In the limb, it manifests more as arm or leg stiffness or rigidity with abnormal posturing. And pharmacotherapy can help, but side effects are common. So these are the medications which we use. It's the simple phrase trihexyphenidyl, also known as Artane, baclofen, and clonazepam. Problem is all of them can cause sedation, imbalance, and confusion. So honestly, botulinum toxin injections are the best way to treat these in my professional opinion. They are FDA approved for cervical and limb dystonia, safe and effective. Start low, go up slowly. That's what the physician should do in the amount of toxin that they inject. And I do recommend finding a physician with experience injecting for that particular condition. This is something you should ask your physician. You need to empower yourselves because you just want to get the best outcome possible. Eyelid dysfunction, very frequent in PSP, also seen in corticobasal degeneration, not as much in multiple system atrophy. This is either 2 forms, blepharospasm or apraxia of eyelid opening. Blepharospasm is this actual contraction of the eyes and kind of, it's very, very frequent, kind of a frequent blinking. And apraxia of eyelid opening is, again, this apraxia is a discommunication between the brain and the intended movement. So it's an inability to open the eyes. Oftentimes people have to use their hands to open up their eyelids. So again, botulinum toxin injections, I would professionally recommend this. They are FDA approved for blepharospasm. Oral medications are less effective. Again, these medications often cause sedation, confusion, imbalance. Eyelid crutches may be a benefit as well. And then if there's double vision in PSP, prism glasses can help as well. So now for the non-motor symptoms, constipation. Stay hydrated. Number 1 most important thing. Now this is the rate limiting factor for staying hydrated is urinating at night, having to get up at night. So what I recommend is slow down in the fluid intake in early afternoon. Then a high fiber diet is the prevention's the best way to treat constipation rather than actually acute measures. So we can do this with, there are other ways, daily Metamucil, prune juice, both have fiber. Miralax is as needed. This is my number 1 go-to for constipation. I find it works. Stool softeners can also be used like Docusate. That's also called, and there's Dulcolax as well. Dream enactment behavior, we call it RBD, REM behavioral disorder. REM sleep is when you blink, it's when you dream, and you should not be able to move. However, in Parkinsonisms, people can often move, more commonly in those alpha-synuclein disorders, PD and MSA and dementia with Lewy bodies, but I do see it in PSP and corticobasal degeneration as well. Insomnia is a huge problem. We need to treat this. So the REM behavioral disorder, the RBD, is talking one's sleep or acting out one's dreams. Insomnia, difficulty either going to sleep or staying asleep. First line, safe, effective, it's in our brains, melatonin, 5 or 10 milligrams. Higher doses can cause paradoxical worsening of sleep. Over-the-counter versions are often 1 to 3 milligrams. They usually don't work. This is not something people wait around for. So after 1 or 2 nights, they give up if 1 milligram doesn't work. So I jump right to 5. And then I go to 10 because that's still a safe dose and it should still be effective. I do recommend, again, getting this by prescription. A family practice physician told me that, who has extensive experience prescribing melatonin, the over-the-counter version seems variable in the amount of actual melatonin that you receive. So 1 milligram could be 2, 3 milligrams could be 1. Oops, sorry, the screen is frozen. Here we go. Okay, clonazepam, now that's the most effective treatment for REM behavioral disorder, But the problem is the side effects. Clonazepam is going to worsen everything that's already bad. So excessive sedation, impairing cognition and balance, that's why I want to avoid that clonazepam. I definitely recommend not taking that unless absolutely necessary. Ribostigmine is a medication used for cognition in Parkinson's disease, but it does have evidence showing that it can help act with the acting out of dreams. Daytime somnolence is a huge problem. First, again, prevention, treat insomnia or sleep apnea. Sleep apnea may require the modern day torture devices, I call them, the CPAP or the BiPAP. They have modified these and they have less intrusive or invasive measures now. And so they can be used without discomfort. Sleep hygiene. These are the things nobody wants to do, but we all should. No television in the bedroom, no ambient light. Warm milk actually does work. Warm milk, and like turkey, has tryptophan in it. Tryptophan makes us go to sleep. Warm baths only if safe. Obviously, be careful. You don't want to slide down and have problems with that. Maintain a continuous sleep schedule as well, a regular sleep schedule. Now, if those methods don't work, then there is a medication, modafinil or Provigil. The problem is it can help, but it can cause irritability and or impulsivity. Drooling, also called SIALORRHEA, that's the term that the physicians will use. Extremely common, can be embarrassing or dangerous. It's the easiest thing in the world to treat. Botulinum toxin injections, 2 pokes, small needle. It's in the cheeks. That's where the glands lie. Botulinum toxin injections are FDA indicated for SIALORRHEA. Simple, safe, and effective. There's a medication called glycopyrrolate, also called Robenal, which you can give. Guess what it does? Causes impaired balance or confusion. Difficulty swallowing, dysphagia is a problem in all 3 disorders. I will say one thing right now, the most common causes of morbidity and mortality in these 3 disorders are falls or choking. Those are the 2 things I always want to prevent. So speech therapy is the first step. Bedside swallow evaluation to see if there are any difficulties in swallowing. A modified barium swallow study, they give you this chalky fluid that's thick, and they actually take an image of it to see if it's going down properly. Then you want to monitor swallowing function. There are eating and drinking strategies. A simple one, tuck chin while you're eating or drinking. So that's after you get something in your mouth, tuck your chin down, and then you can swallow. It goes down the right pipe that way. Modified diet and fluids, I found this one to be very effective. There's something called Thicket. You can get this at any pharmacy. You just put it into any kind of thin liquid and it makes it thicker. You should consult with your speech therapist first, because if there's a problem with thick liquids, then you're creating a problem. But make sure if there is a problem with thin liquids, you can get this over the counter. Maintaining oral hygiene is very important, brushing teeth. I saw a question later about difficulty opening one's mouth. In order to maintain this oral hygiene, botulinum toxin injections for the dystonia, that's what's causing the excuse me, the mouth to stay closed. And so if you can get the mouth open, then you can maintain oral hygiene. Assistive mealtime devices as well can be useful. And then ultimately a neglected but extremely important point is the discussion of a PEG tube. The PEG tube, it can be reversible, okay? So you can get a PEG tube and then have it removed if it improves. And it's an important selling point because nobody really wants these tubes, and it's hard to convince our loved ones to get that. So now how do we treat the neuropsychiatric symptoms? Depression, anxiety, antidepressant, of course. Now, I recommend SSRIs or SNRIs, not TCAs, tricyclic antidepressants. They can cause side effects. These are amitriptyline or nortriptyline, cause, again, confusion, sedation, and imbalance. Inappropriate laughing or crying. I see this most frequently with PSP. It's called pseudobulbar affect. You may have seen commercials for it on TV. And this is very treatable. The medication Nuedexta, dextromethorphan is very, very effective for this. There is a potential for a cardiac arrhythmia with this medication that needs to be monitored, so please check with your physician. I've had the honor of creating the CUREPSP Centers of Care in coordination with the nonprofit organization CUREPSP. I wanted to let everybody know about this, that these are a network of centers in the United States and Canada designed to increase access and improve care for PSP and CBD. There are 4 goals, major goals, to help PSP and CBD patients find the best possible local and regional care, to increase awareness of PSP and CBD spectrum disorders, providing educational material to patients, caregivers, and healthcare professionals, to provide local regional resources for physicians seeking information about these disorders, and to promote collaboration between the centers that are involved so we can optimize the standards of care. These disorders are neglected. There's no other way to say it, and we need to do a better job of making sure that's not the case. You all deserve the best care possible, and that's what we're here to do. For MSA, I'm sure that people there are wondering, what do we do for MSA? I'm sorry, real quick, there's the link at the bottom for the PSP. If you do need to find your nearest center of care, you can use that link. MSA, Dr. Kathleen Poston, she works here at Stanford as well. She's an absolute genius, and she is part of the MSA Coalition, I believe, as well. They have put together centers of excellence for multiple system atrophy. So that is another resource that you should definitely pursue if that is what is your particular situation. So in conclusion, there is unfortunately not currently a cure for atypical Parkinsonism, but again, I have hope because of what I stated earlier. There are several symptomatic treatments which can improve one's quality of life. Each individually may be minor, but in some they can make a significant difference. Please seek out a movement disorder specialist, preferably one with expertise in atypical Parkinsonism. Always be on the lookout for clinical trials, and there is always hope. If you see a doctor and he says, I don't know what to do, you find another doctor, okay? And thank you all. I'm here to answer questions now.
Thank you, Dr. Bluett. So now we'll begin our Q&A. We've received over 200 questions in advance. We've narrowed this down to about 50 questions, which are on the next several slides. We'll try to get through as many of these questions as possible in the next 30 minutes. Dr. Bluett, if we come to a question that you think you've addressed in your earlier remarks, please let me know so we can skip that question.
Yes, ma'am.
Okay, so the first question is, are there treatments for rigidity?
Yes, and I kind of want to address these first three questions together, if possible. So rigidity, it's a form of stiffness. So there's I see here our joint or muscle contracture is the same thing as dystonia. So I want to separate these terms for you and tell you how they're all integrated as well. So rigidity is stiffness. It's a broad term that includes spasticity and dystonia. Spasticity essentially is a fixed contracture of a fixed position of a muscle due to muscular contraction. Dystonia is again kind of intermittent, so it comes and goes. There are treatments for these. The medical treatments for rigidity, number one is baclofen. That's usually used for spasticity. For the dystonia, botulinum toxin injections I find are the most effective, but also Artane, that trihexyphenidyl, can be effective as well. Preventative measures, it's difficult. You do not want contractures. Contractures are when it's beyond the point where you can't Botox it. You can't use botulinum toxin injections to treat it. So prevention is definitely important. If there is rigidity, spasticity, or dystonia without contractures, please talk to your doctor. Tell them that we don't want to get this to a contracture state where we can't treat this with the botulinum toxin injections. If you are at the contracture state, there are orthotic devices that you can use. I don't recommend those in the beginning, early stages, because there's some literature that states that orthotic devices can actually cause dystonia. And I'm talking about braces and things of that nature. So I'm being very long-winded, I apologize. But hopefully to sum up quickly, botulinum toxin injections would be the best and most effective way to treat these. But then there are also medications such as baclofen for spasticity and Artane for dystonia.
Okay, so our next question, CBD is one-sided. Are there any robotic devices that can be used to strengthen the affected side?
Very interesting question. Whoever wrote this, I'm proud of you. You're thinking ahead. I think that probably will be the wave of the future. They're doing this for stroke. They're not doing it for CBD yet. So there were currently no robotic devices to strengthen the affected side. But again, it's not weakness. This is a very common misconception. There's no weakness involved in these disorders. It's slowness and stiffness. And so what we want to do is improve that slowness and stiffness either with medications or the Botox injections.
What can be done about mutism, and how can we communicate?
Speech therapy does an excellent job of addressing this. That's the first place you would want to start. I had a patient who had lovely patient, ataxia and dystonia, could barely talk, and she had a keyboard with which to type. So if that is a possibility, please speak with speech therapy about that.
Is there a treatment for the eye tracking problem?
Yes, there's physical therapy, and this is again the importance of physical therapy that is specialized in the treatment of Parkinsonism. If they're trained in Parkinson's disease, likely they have some experience with atypical Parkinsonism. Again, this is Chris Sampiri's work back in 2000, I think in 10 or 9, and it is basically showed that eye movement in conjunction with physical therapy exercises can help overall coordination. So there's not a treatment, there's not a cure for it, but there can be improvements, and this should be discussed with your physical or occupational therapist.
Okay, how can we help someone clear his, her throat? Person is choking on phlegm and has a hard time coughing it up.
Terrible problem, sad problem. This needs to be addressed. This is a risk for aspiration, which is the #1 cause of morbidity and mortality. We don't want this to happen. Suction devices are available. This is something that should be discussed with speech therapy. Please ask your physician or speech therapy. Oftentimes they can provide this to you at home.
We have lots of questions on this topic. It's about pain management.
Yes, of course. So I see this more with corticobasal degeneration and multiple system atrophy, the pain issues. I think it's best to actually get a pain management specialist involved if pain is an issue. I've tried to manage it myself. It's difficult. It's very difficult. And sometimes it's going to require, the opiates and things of that nature, which I tend to try to avoid. So I do recommend a pain management specialist for this, but a lot of times the pain is due to stiffness, spasticity, dystonia. So again, trying to relax those muscles would be my first intervention.
What about urinary incontinence? Botox for this?
There's botulinum toxin injections for bladder spasticity. It's usually used in multiple sclerosis. I honestly don't, it can work, but it oftentimes does not work. So usually, the urinary incontinence that happens in these disorders is overflow incontinence, where you don't know that you have to go, but you do go. So there's, it's a frustrating problem. I probably would not recommend botulinum toxin injections for this, although you can discuss with your provider. Undergarments, honestly, are the best way to address this. A bedside commode may be necessary. We don't have great answers.
Dealing with severe leg cramps at night.
Leg cramping, first thing you want to do is prevention. Hydration, as long as it's safe and tolerated, tonic water has quinine in it. Quinine can relieve cramps. Magnesium, also supplementation, can also relieve cramps, but can cause diarrhea. Remember, everything you take has side effects, so always be careful and discuss with your physician. And now this could potentially be a dystonia causing the leg cramps, and so it may be amenable to CARBIDOPA-LEVODOPA as well.
Any suggestions for dental care as this person's brother's mouth will not open?
Again, this is what I was saying before. So this is probably an oromandibular dystonia. My guess, it's called a jaw closing dystonia. I would recommend botulinum toxin injections in the masseter. Again, this is please don't take this as gospel. This is just my expertise here. But I would recommend botulinum toxin injections in the masseters, usually for this. And that can open up the mouth and make it so that you can provide the dental care.
Okay. How do we deal with stridor during the day?
This is a difficult question. This is probably the one that stumped me the most. I would recommend discussing with your physician possibly a pulmonology referral. They're lung specialists. Stridor is very hard to treat. It can be due to some aspiration, some thin liquid aspiration, and so therefore, if there's SIALORRHEA or drooling, then you want to treat that. I would talk with speech therapy about suction devices because that can help as well. But this was a difficult one. I don't have a great answer for that.
How can cognitive problems be treated?
I hope that the slides provided some help with that. There's a lot of different areas of cognition. There's neuropsychiatric, then there's also actually cognitive decline, memory loss. There's medications, for Alzheimer's, they use donepezil or Aricept. For Parkinson's, we use ribostigmine or Exelon. Those are the interchangeable names for those medications. Staying alert, a patient, please don't, I want to make sure I don't neglect to say this. A patient of mine recently told me about keeping goals for the day. And I thought this was really, really, really important. So you can keep track of what you're doing. The relation to this with cognitive problems is keeping focused, keeping attentive, keeping in the moment. I think those are all methods that can help before going to medications.
Do patients with these disorders hallucinate?
Tend not to. That's usually not a problem. PSP, corticobasal degeneration, MSA usually don't have hallucinations.
Does cannabidiol medical marijuana help these disorders? Lots of questions on this topic.
Of course there is. We're in California. So there's, I'll give you my generic spiel. So there's two parts of marijuana. There's THC, which I call the Woodstock portion, and there's CBD, which is the medicinal portion. CBD is cannabidiol. CBD does help. They've shown it actually does help with tremor. It can be used to relax. I think that's probably the main mechanism of action. It's a calming agent. And CBD itself, not THC, CBD doesn't really cause cognitive impairment. There are also topical forms of CBD you can use as well.
Okay, lots of questions on this topic, stem cell therapy.
Of course, as well. I was very, 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 very hopeful about the stem cell therapy. The problem is getting the stem cells to the right part of the brain. So they're working on some studies in Parkinson's disease where they're actually infusing or injecting the stem cells into the part of the brain called the putamen, which is where part of the area of the brain that's affected by Parkinson's disease. So currently right now, no, there are not effective known stem cell therapies, but there are research underway. And if I can jump ahead to the next two questions, because
Go ahead.
Sorry, Sharon. And it's because I have a similar theme I want to tell you about these. Be careful. I'll tell you a quick anecdotal story. Well, I'll save you the anecdotal story. I'll just spare you. But let me just say briefly that you always want to make sure that what you're getting is benefiting you and not the person providing it. That's the most gentle way I can say that. There's a lot of people out there who want to make money. And you need to understand that I just want the best for you, and just be careful. We all have hope, but make sure the hope is focused in the right area. So for example, hyperbaric oxygen therapy, there's a lot of centers that have this now. There's no real evidence that shows that it works for these disorders. Please discuss with your physician. Don't be taken advantage of. That breaks my heart.
Can vitamins slow the progression of the disease?
Not that I know of. There are no vitamin supplementations currently.
What about the dopa pump?
So Duopa is indicated for fluctuations in the when treating Parkinson's disease. So when you're taking carbidopa-levodopa, when the medication starts to wear off or it doesn't work as effectively, you have the pump, which is like a peg tube that infuses the carbidopa-levodopa into your stomach. So this is not indicated for MSA, PSP, and CBD, again, because the carbidopa-levodopa often doesn't work, unfortunately. So I would recommend against that. The one case would be a PSP Parkinsonism if the carbidopa-levodopa is effective.
Okay, next question is, what is the process and value of brain donations for research in these disorders? And I'll take this one if it's okay with you.
Of course.
Okay. Brain Support Network has helped over 650 families donate a loved one's brain. And the two reasons for brain donation are to confirm the diagnosis and to enable research into the causes and the treatments and the cures for neurological conditions. About half the families who've had clinical diagnosis of PSP, MSA, or CBD found out upon brain donation that their family member actually had a different disorder. I suggest you visiting the BSN website, brainsupportnetwork.org, for details about the process of brain donation. And we are happy to make brain donation arrangements for you or your family. Okay, and the next question then is autopsy the only way to confirm diagnosis, and can PSP, CBD, and MSA co-occur?
Thanks, Sharon. And first of all, I just wanted to echo what Sharon just said, that the brain donation is invaluable. That is absolutely invaluable. We're still in the process of trying to figure out cures. The gold standard of diagnosis, to answer this next question, is autopsy. But we need brains to help and to be able to help future people who suffer from this. So to answer the specific question right now, the autopsy is not the only way to confirm a diagnosis. I guess if you want to say confirm, yes. Specifically, if you want a 100% stamp of approval. However, with PSP, for example, the diagnostic accuracy is about 80 to 90% currently, so it is fairly accurate. CBD and MSA as well have a fairly high rate of accuracy of diagnosis. MSA is more difficult to diagnose. The problem being that the diagnostic criteria includes this urinary incontinence. And oftentimes for gentlemen, the prostate gets large. We all have problems with urination. And so it gets confusing as to what's what, also with the lightheadedness when standing. So to focus and specifically answer, yes, autopsy is the only way to confirm specifically. PSP and CBD can co-occur. MSA does not co-occur with PSP and CBD.
How to find, movement disorder specialists for neurologists, PTs, OTs, or exercise instructors trained in LSVT, big or power, speech therapists, special workers.
Great. Thank you very much for asking this question. There's a way it's called LSVT find a clinician, and LSVT is Lee Silverman voice training. It's used for Parkinson's disease. It focuses on amplitude of vocal sounds and also movements. And so if you go to look up on Google LSVT find a clinician, you should be able to find this.
Okay, next question. Can bladder training work if there is dementia?
Oh, I'm so sorry. I want to also recommend also that the local American Parkinson's APDA, which is led by Robin Riddle, who is a superhero. So please use that as a resource as well for finding your local movement disorder special neurologist, and also for speech therapist or social worker. In regards to a DO, please don't be skeptical. I'm a real doctor. So it is different from an MD. It's Doctor of Osteopathic Medicine. We basically, to put it in layman's terms, take a more holistic approach. It's supposed to take the mind, body, and spirit into approach. There's something called osteopathic manipulative medicine, which is kind of a form of massage meets chiropractic, which I personally don't do, but it is valuable in a lot of cases. Just FYI, I personally myself, I took my DO and MD boards 3 times. I did all of them. You have 3 different steps going through medical school. So I took the DO step 1, MD step 1, DO step 2, MD step 2, DO, did all of it together. So very similar overall.
Okay, sorry, I skipped over that one question, and I'm glad you picked it up.
It's okay.
So I go back to, can bladder training work if there is dementia?
Yes, it's more difficult though. I think we all know this. And so yeah, bladder training can work, but honestly, I think if there is dementia, it's gonna be more difficult because there's impulsivity. There's the basic way that your urination process works is the frontal lobe communicates with your spinal cord, communicates with your bladder. With dementia, the frontal lobe is impaired, and so it's more difficult for urination in general. So the bladder training can work if there's dementia, but it depends upon the severity of the dementia. So if it's too severe, I would recommend potentially a pharmacological agent or undergarments, but bladder training can help better if there's less cognitive deficits.
Okay. Can breast support be improved using the expiratory muscle strength trainer, for example?
Definitely. This is another reason you get speech therapy involved. There's also pulmonary function specialists. That should be referred from the physician or from the speech therapist as well.
And mindfulness or meditation help with anxiety or depression, even if there is dementia?
If there's dementia, that's going to be difficult to get somebody to cooperate with to do. But definitely, mindfulness and meditation. My whole logic and motto or going forward with medicine, start with something that's not going to cause any side effects. Mindfulness meditation, there's no risk for that. That's relaxation. The next step is then you get to medications, which all have side effects. So please try to start with things that are less invasive before increasing. And if there is dementia, I would try it, but it may be difficult.
Is it possible to recover from impaired mobility via PT?
Yes. Now, it depends upon the level of severity. I oftentimes, if there's impaired mobility in these 3 disorders, I'm thinking spasticity or dystonia probably causing it. So I would augment the physical therapy with the botulinum toxin injections. A note of caution, if there's spasticity or dystonia in the lower extremities, botulinum toxin, what it does is it weakens muscles. And so you should be very careful about getting it in the lower extremities because it can cause weakness and falls. Just my 2 cents. Hello?
If opiates affect cognition and cause hallucinations, what kind of treatment can be offered for pain relief?
Great question. And so again, this is a difficult one. The pain in these three disorders is usually due to the spasticity and dystonia. Baclofen is probably my first go-to. Baclofen side effects are lightheadedness and potentially confusion, but nowhere near to the degree of opiates. So I would discuss botulinum toxin injections to see if you can treat the tension and spasticity of the muscles or rigidity or dystonia, and then potentially other agents aside from opiates.
Hospice and palliative care do not want to approve speech therapy or physical therapy. Should I argue with them about this?
This is a frustrating, I am with you 100%. There is this weird it's once you go into hospice, they want to not allow you to proceed with any other kind of interventions. And so I probably would not argue with them about this. Talk to your physician. Let us argue with them. We've gone through it a million times. You're going through enough yourself. You need help. Talk with your physician. Ask them.
Okay, we're going to get back to a slide that was skipped over. What are some common and easy exercises that patients can do without fear of falling?
Here is a simple one, and it's again, it depends upon the severity. Standing up with your arms crossed. This is more for early stages of these disorders. I recommend being there, monitoring, but that is a simple one to strengthen your core. Physical therapy should be able to provide you with home exercises that specifically address this question.
Which of these therapies are appropriate in late stages, or which of these therapies are not appropriate for late stages?
This all depends. This is a very individualized question. So it needs to be, every treatment plan should be custom designed for how you're doing at that moment. Obviously, if somebody is wheelchair bound, then you don't want to have them stand up and try to do exercises. It's unsafe. There could be falls. But speak with your physical therapist about this one.
Okay, do all of these treatments apply to advanced Parkinson's disease, Lewy body dementia?
No, it's again, I like to take an individualized approach with everything, and these are different disorders. So Parkinson's and Lewy body dementia, I see more improvement with carbidopa-levodopa. I know that the slide said that there's a poor response with Lewy body dementia, but I see a little bit better than I do with CBD, PSP, and MSA. So, however, the other things that we were talking about, cognition, ribostigmine, the SIALORRHEA, motor symptoms, yes, those should apply to those as well.
Are there any new drugs for non-motor symptoms in the pipeline?
There are lots of things. Yeah, for REM behavioral disorder, they're looking at, I can't tell you the compound, but they're looking at other ways to treat this. I think honestly, it's an under-addressed need. These non-motor symptoms. The motor symptoms are obvious. When a physician sees you, you can see the motor symptoms. The non-motor symptoms are things you have to bring up to the physician. So there's not as much research, but there are potential therapies in the works for these.
What can we do if the insurance company denies eye therapy?
That's a hard one. Usually you can do a letter of appeal. The physician should help you with that. Primary care is usually the first source of that, but your movement disorder specialist should be able to help as well.
Oh, how do we optimize therapy, OT, PT, ST, if we only get a certain number of sessions approved? What are the most important goals?
And yeah, that's a limitation as well. So there's usually 15 sessions per year that is approved for the therapy appointments, and so you want to make sure that you get the most out of it. I prioritize falls number one, falls and choking. Make that your priority. Everything else is troublesome but not life-threatening. Those are the two things that are the most dangerous. Please focus on preventing falls and preventing choking.
When should my family members stop driving?
With these diseases early. There's concerns about the slowness of movement, also about judgment and orientation. And so I think it's better to be safe than sorry. Let me add on to that, because that's my least favorite thing to address. My job is to give independence, not take it away. And there are potential, you can do driving evaluations at some occupational therapies. Stanford has that, for example. And so you can actually do a kind of simulated driving test to see if one is safe to drive.
Can medications affect cognition?
Definitely, all of them, basically. The ones for urinary incontinence, oxybutynin causes confusion, baclofen, artane, the trioxyphenadil, clonazepam. Most of them will affect cognition. Medications are our number one tool, but they're also our number one enemy. Be careful, they all have side effects.
What matters more, my precise diagnosis or how I treat my condition?
Treat your condition. The precise diagnosis is educational, it's academic. Treating the actual what's real is the most important thing, in my opinion. They're both important, though.
What can a caregiver do to help?
Oh, poor caregivers, I love you, all of you. You are the best people in the world. You're going through a hard time. I'm going to tell you what I think you should do is to not put too much on yourself, because oftentimes I see people literally breaking their backs. For example, holding somebody who's going to fall, they have a brace and it's attached to them, and give yourself a break. Find the tools, find the resources, talk with your physician, have a social worker talk to you. APDA, LSVT, all of these things, use these resources, use your physician.
Is there hope?
Yes, first of all, there's always hope, and I mean that. And I'll use the anecdote of Huntington's disease. So Huntington's disease has been around forever. Most people here probably heard of Huntington's disease. The major symptom is chorea. I honestly, these are some of the most wonderful people I've ever met in my life with Huntington's disease, and I did not think there would be a cure potential, and we may have one now. It's a gene modifying therapy. Point is, I think there should be a domino effect. Once we can get a cure for any of these kind of neurodegenerative disorders, it should be translatable, similar to how cardiovascular interventions translated to stroke interventions. And I think that is our hope. And so hopefully, even if we treat MS, multiple sclerosis, we should have a way to potentially be able to impact these other disorders. There is hope. Keep it alive for now. Put good Band-Aids on and keep going.
Okay, so we have a couple extra questions here that we've added on. What about VitalStim for swallowing?
VitalStim is great. I was skeptical, but it really does help. I've seen a lot of people who told me that they really do think it's helped. VitalStim is a kind of electrotherapy where they actually stimulate the muscles of the pharynx on the neck, and so they contract, and it helps you with your swallowing. I do think it is effective.
How is PISA syndrome treated?
PISA syndrome is very hard to treat. It's PISA syndrome, for those who don't know, it's named after the Leaning Tower of Pisa. And the idea is that basically somebody tilts to the side, their trunk is distorted. So I've tried Botox injections, botulinum toxin injections for this into the extensor muscles of the back. It helps, but it doesn't get it cured. It's a very difficult thing to treat. Another thing I will say also is I've seen this with everybody with their caregivers get frustrated with their loved one with PSP, CBD, or MSA about their posture. And it's such a battle. The posture is hard to maintain. Patients, try to keep your posture, try to keep a straightened back. I just straightened up myself. Caregivers understand this is part of the disease. For the PISA syndrome specifically, I would talk with your physician to see if botulinum toxin injections could help.
Okay, I think our last question here is, are there assistive devices for speech?
Yes, definitely. And so again, going back to that keyboard, so I had a patient who was unable to vocalize. She had severe dysarthria, and there was a keyboard that really helped her. Talk with speech therapy about that. They have great tricks up their sleeve and great recommendations for this.
Oh, I lost.
Hello.
Hello, I lost sound here, sorry.
Oh.
Are we back? Okay.
Yeah.
All right. So we're on to another slide here for further information. Brain Support Network's top resource list for PSP and MSA and CBD. These are what we think are the top English-speaking language resources from around the world on these disorders. www.brainsupportnetwork.org/PSP, www.brainsupportnetwork.org/MSA, www.brainsupportnetwork.org/CBD. Join Brain Support Network email list for PSP, MSA, and CBD, www.brainsupportnetwork.org www.brainsupport.network/join. Brain donations to support PSP, MSA, and CBD research, www.brainsupportnetwork.org/brain donation. So for further information on these sites, the American Parkinson's Disease Association operates several information and referral centers around the U.S. The center coordinators can refer you to healthcare professionals such as movement disorder specialists, physical therapists, and others. And if you live in Northern California, you can contact information referral centers at Stanford. As Dr. Bluett mentioned, there are several centers of care for PSP and CBD in the U.S., including at Stanford. And you can contact the MSA Coalition for suggestions of good movement disorder centers for treatment about MSA. Finally, if you'd like to make an appointment with Dr. Bluett or anyone at Stanford, see the phone number on the screen. So to complete the, in a moment, let's see, we'll hopefully be able to direct you to a survey by joining the webinar. You will be directed to a survey, and hopefully you will complete that. That information will be invaluable to us for further webinars that we put on. So on behalf of Stanford and Brain Support Network, I'd like to thank you all for attending the seminar today. I'd like to thank you, Dr. Bluett, especially. In about a week, everyone registered to attend the webinar will receive an email about accessing today's webinar recording. If you are one of Brain Support Network's email list, you will receive notice that notes from today's webinar have been posted to the BSN website. And if you have any questions, you may reply to your webinar registration email. Thanks again.